Come in.
Hello, sir. How are we doing today?
Great, how are you?
I'm doing pretty well. All right. If you don't mind me asking, what's your name and date of birth?
Ben Olson, October 10th, 1991.
All right, beautiful. Well, my name's Romi. I'm going to be the PA taking care of you today.
Nice to meet you.
All right. So is there a reason you came into the office today?
That's abdominal pain.
Abdominal pain? Is there a specific location at all, or?
No, just kind of all over.
All over the place?
Yeah.
All right, cool. So what we're going to do, generally what I would do prior to doing the abdominal exam is I'd listen to his heart, take his blood pressure, listen to his lungs, take his temperature, but for now we're just going to go ahead and jump into the abdominal exam, okay? So what I'd like you to do is just go ahead and lie down for me, sir. And generally at this point I'd ask if the patient is comfortable, and if not, I would give him some pillows or something to go ahead and just make him feel a little bit more comfortable while we're doing the exam, okay? And what I would do, generally the patient would be draped, and the thing that would be exposed would be kind of to the superior iliac crest all the way to the xiphoid process here. But for now, unfortunately, we don't have a drape to give this patient. So what I'd like you to do is just go ahead and bring your shirt up right to the bottom. Oh, that's good too. All right, so what I'm gonna do first is inspect the abdomen. So what I'm trying to look for is hernias, maybe any discoloration, maybe any weird contour with the stomach. Right now, the stomach does look flat with the ribs and everything, so it does look good. So what I'm gonna do now is go to eye level, see if there's anything abnormal. Maybe any scarring too. And generally, if this patient were to have a hernia, what we could do is we could ask the patient, you don't have to do this now, sir, but what we could do is ask the patient to go ahead and lift his head and shoulders. And if it's a deep hernia, when he lifts his head and shoulders and I were to maybe palpate it, give it a little bit of pressure, he wouldn't feel as much pressure. But if it was more of a superficial hernia and he lifted his head and shoulder and I were to go ahead and press down a little bit, he'd feel more pressure. So that's how we can kind of distinguish whether it's going to be a deep or superficial hernia, okay? So what we went ahead and did was the inspection, and everything looked normal, okay? So the next thing we're going to do is going to be auscultate, all right? And what I'm going to do is I'm going to listen to all the quadrants. So we have our quadrants set up as in we're going to start with the right lower quadrant, then move up to the right upper quadrant, then move over to the left upper quadrant, and end at the left lower quadrant, okay? All right, and what I'm going to do first is we're going to go ahead and start with the right lower quadrant. And what I'm trying to hear is just normal bowel movements, hopefully no blockage. All right. All right, is this a little cold? Did you want me to warm it up at all?
Good.
No, all good? All right, cool. All right. So what I'm hearing right now is just regular bowel movements, nothing abnormal. All right. And what we're going to do now is move to the right upper quadrant. So while I'm up here too, I'm going to go ahead and hear the liver. So I'm trying not to hear any humming or any like friction rubbing or whatnot. Generally, if you hear friction rubbing, you might have an inflamed liver or a hepatomegaly. Okay? So first I'm going to go ahead and try to just listen to the liver. So I'm going to go underneath here. All right, sounds good. And when I mean friction rub, it's like kind of the sound whenever you put your hands through your hair. That's the sound you should be getting whenever you listen to this. Now let's just listen to the quadrant. Yeah, you definitely just ate. All right, and now we're going to go to the left upper quadrant. All right, sounds good. Nothing abnormal there either. And what we're going to do now is go to the medial axillary here. And I'm going to do the same thing like I did with the liver. I'm trying to hear anything that might be like any friction rubs or any hummings too, okay? All right. All right, sounds normal. All right, and now we're going to go ahead and go to the left lower quadrant, okay? And here too, another sound you could hear is like tinklings and rushing too. But again, it sounds like regular bowel movements. If it's tinkling or rushing, you would think of like small bowel obstruction, okay? But it does sound normal. All right, and now what I'm gonna do is I'm gonna flip over to the other side of my stethoscope and we're gonna go ahead and listen to the arteries, okay? All right, so what I'm gonna do is I'm gonna listen to the aortic artery. Let's going to be a little bit above the belly button when you listen to it, okay? All right, sounds good. And now we're going to go ahead and move to the renal arteries. Oh, sounds really good. All right, and now the other renal artery. Okay, and now we're going to go ahead and go to the iliac arteries, okay? All right, sounds normal. All right, sounds normal. And then generally we'd go to the femoral arteries too, but just for privacy sakes, we're gonna go ahead and leave that alone. And something else I did forget on inspection is we're also trying to look for maybe any peristalsis down here in the bowel area, or any like AAA here. So maybe whenever you look down at their chest, you can see a little bit of pulsation right here where the aortic valve, or not aortic valve, but the aortic artery will be. All right. So we just did inspection, we did auscultation, so now we're going to do percussion, okay? And what we're going to do is we're going to start the same way, where we're going to go right lower quadrant, go into N formation. And what I'm going to do is I'm going to use my non-dominant hand, the middle finger of my non-dominant hand, and rest the distal portion of my middle finger on this gentleman's right lower quadrant, okay? And then I'm going to use my dominant hand, the middle finger, and just go ahead and hit the distal portion of my finger. And what I'm trying to hear is just, well, at least in this area, just tympany, okay? All right, so let's go ahead and listen. Sounds good. Doesn't sound like any blockage or anything. All right, sounds good. So the right lower quadrant sounds good. So now we're gonna go ahead and move to the right upper quadrant, okay? And generally, some portions of this right upper quadrant, you're going to hear mostly tympany. But here you're going to hear dullness, and the reason why you hear dullness here is because of the liver. So while we're in this quadrant too, we're going to go ahead and kind of estimate the size of the liver too, okay? So let's just start here. Oh yeah, sounds good. Nothing but tympany. All right, let's see if I can hear some dullness. All right, so what I'm going to do now is I'm going to go ahead and go to the mid-clavicular point. And if you don't mind, do you mind raising your, yep. So what I'm going to do is I'm going to start from the nipple line, above the nipple line, and go down. And what I'm trying to hear is whenever it goes dull, that would be kind of the border of the liver, okay? So we're going to start here and work our way down. And generally right now, what I would do would be mark the border. So I'm gonna pretend like I'm marking it, okay? So we're gonna go ahead, not gonna mark you for real. We're gonna mark it right here. And now what I'm gonna do is I'm gonna start from the belly button, below the belly button, and work my way up and do the same thing like I did when I was above the nipple line. So if you'd like to, you could go ahead and pull down your shirt a bit. There you go. All right. And where I'm assuming the liver will be based off my observation and me doing my percussions, be right here. All right. And now what I'm going to do is I'm going to go ahead and continue my percussion and move to the left upper quadrant. All right. All right, sounds good. And now what I'm going to do while I'm here too is we're going to go to the mid-axillary point right here. And we're going to go ahead and try to percuss the spleen. So what I would like you to do while I'm going to do the percussion is just take a deep breath in and out. And what I'm trying to hear is straight tympany through the entire thing, because generally the spleen won't be able to be percussed or palpated either. But once we get to the palpation, we'll go ahead and talk about that a little bit more. All right, you ready? Deep breath. Let it out. All right. And what we just noticed is tympany throughout that entire process. So it doesn't seem like he has any sort of enlarged spleen, okay? So the next thing we're gonna do is move to the left lower quadrant. And I'm gonna do the same thing as well. All right, so everything sounds good. And generally what we do, if we had a patient that seemed like he had a lot of fluid in his stomach, so for instance, ascites, what would happen is when the patient is laying down, the air bubble would be kind of generalized in the middle, and it'd be dull around the sides. And let's say if this patient were to flip over to the other side, to this right side or left side, and also while I'm doing that too, I'd mark where essentially the tympany ends and the dullness starts, so I could kind of mark my parameters and see, like, if you were to move to the other sides, would it be consistent? So if you were to move to the other side, you don't have to, but I'm gonna go ahead and verbalize this. But if you were to move to the other side, what I would do is I'd start from the bottom portion and work my way up. And I'll try to hear where the tympany again starts and where the dullness ends. And at that point, that's where I would mark it as well. So that's one thing you'd consider too. And then pregnancy as well is another thing. And with pregnancy, it's gonna be kind of the opposite of ascites. So in the center, it's gonna be dull. And then whenever you get to the outer portions is when you're gonna have tympany. And then we have another thing where we could worry about it, which is uterine fibroids, which is kind of gonna be kind of a tumor, all right? And with that, all this portion here would be dull because of the actual tumor itself. And the outer portions, you'd have a little bit of tympany too. All right, but this gentleman, again, he doesn't seem like he has any ascites. I hope the guy doesn't have any uterine fibroids or any of those stuff. So he seems good, but just for educational purposes, those are the other tests that you could conduct to find out further issues if presented. All right, and now the next thing we're gonna do is gonna be the palpation. So it's separated into two parts. You got the light palpation, and then you got the deep palpation. All right, and with light palpation, again, I'm gonna start with the right lower quadrant, work in an N formation. And what I'm gonna do is I'm gonna slowly kind of rub my hand around all of his portions and lightly lift it and slide it over. So let's go ahead and do that. All right. And generally, someone that would have maybe ascites, or not ascites, but appendicitis or anything, me doing that might bring up some pain or something, okay? All right, so let's continue. All right. And while I'm here, we'll do that when we do deep palpation. So let's go ahead and continue. All right, looks good. Nothing abnormal there. All right, feels good. Nothing abnormal. Now we're gonna do the deep pressure test. But before I do that, we got some signs that we should go over, okay? So we have the Murphy sign, which we're gonna go ahead and test like for maybe some patients that might have cholecystitis or any sort of inflammation of the gallbladder. And then we also have the psoas sign. Then we have the obturator sign. And then we also have like the McBurney's point. We also have rebound tenderness and Rosving sign, okay? So what we'll go ahead and do is we're gonna go ahead and move to the Murphy sign first. So I'm gonna do that, and then we're gonna also try to feel the liver and everything too. But let's actually start with the liver. That sounds a little bit better. Generally, if the patient would be obese, there'll be like a hook thing you could do as well, the hook method, where a patient is somewhat skinny. So we're gonna go ahead and do the generic method with it, okay? So what I'd like you to do is go ahead and let go, and I'm gonna press my finger in and push down. So go ahead and let out air. All right. All right, now go ahead and breathe in. All right, and what I'm trying to feel here is, let's say this patient had a cirrhosis liver. It wouldn't be spongy, and it would be very hard, irregular, but with this patient right here, he had a very spongy, soft, sharp borders, okay? So I was able to feel everything there, all right? And now let's go ahead, while we're here on the upper portion of the abdomen, let's go ahead and see if this patient might have splenomegaly, okay? So what I'm gonna do is I'm gonna stick my left hand underneath this person's rib cage. I'm gonna go ahead and put my fingers underneath kind of the 6th, 7th rib cage on the right or the left side of this patient here. So I'm gonna do the same thing where he's gonna breathe out. I'm gonna put my fingers in. All right, now go ahead and inhale. All right, and I don't feel anything. That's a good thing. We don't want to feel that at all. All right, so that's good. And next thing is, let's say this patient might have appendicitis. Let's go ahead and test for rebound tenderness. There's actually 3 tests you could do that. So what I'm going to do, sir, is I'm going to go ahead and push down and let go, and you're going to let me know which hurts more, okay? All right, you ready? 1, 2, 3. Pushing in? Okay, good. That's a positive sign. And now let's do the Murphy sign, okay? And again, like I said in the prior few seconds before me doing the liver exam and spleen exam, this is going to be measuring the not measuring, but seeing if the gallbladder is inflamed. So generally when I do this and I push in underneath the liver, when he inhales, what I want to do is pay attention to the patient's face or his expression. So if he stops breathing or he has like a look on his face like he's in agony or whatnot, that would be a positive sign. All right, so go ahead and breathe out real quick. All right, now breathe in. All right, and we have a negative Murphy sign there, so we don't have to worry about any cholecystitis or anything, okay? And now we're going to do the psoas sign. So again, this is something with appendicitis as well. And what it's going to be is I'm actually going to do essentially rebound tenderness, but on the opposite side. And when I push in, he should feel the tenderness or the pain where his appendix should be, okay? So I'm going to do the same thing. You ready? 1, 2, 3. Where did you feel the pain? All right, looks good. All right, now I only have 2 more exams to do. So we're going to do the obturator sign. All right, so what I'm going to do is I'm going to lift this patient's leg up, bend his knee, and I'm going to go ahead and kind of flex his hip medially in the body. And generally this will kind of like instill pain in the patient where his abdomen is located, okay? You ready? All right, you feel anything at all when I do that? Nothing? Feels good? All right. And last but not least, the last special exam we would do would be the psoas sign. And what this is I would essentially put pressure right above his knee here on his thigh and ask him to lift up. And generally, this patient would feel pain right where his appendix would be. Do you feel any pain at all, sir? No? All right, you go ahead and set it down. All right, and now let's go ahead and go back to the deep palpations. So again, I'm going to go ahead and palpate with the right lower quadrant and work my way around, okay? You ready, sir? And let me know if this is uncomfortable or if you feel any pain or anything, all right? And you generally want to put your dominant hand on top and push down. You feel anything at all, sir? No? All right, let's go to the right upper quadrant. Any pain? No? All right, and now let's go to the left upper quadrant. Any pain? Feels good? All right, and now the left lower quadrant. Huh? Any pain? All right. And another thing we could do is we could go ahead and actually feel for the aortic artery, okay? So it should be a little bit above the line, and you're looking about, generally on average, about 3 centimeters, so not too big. So let's go ahead and try to feel for that. All right, I got a nice pulse there, okay? All right. And that concludes this abdominal exam. I would like to thank my patient, Ben Olson, for participating. And if you did have any questions or any concerns, please let me know. My name is Romi, and I hope you guys appreciated the video.